Okay, we just start introducing myself, and then we will move forward with this webinar. First of all, thank you very much for joining. I'm Enrico Tricanico, and I'm a project coordinator at UPATI. This webinar today is in the framework of a project where UPATI is a partner, and this project is called Jeremy. It is funded by the European Union under Horizon 2020 or Horizon Europe, sorry. And the lead partner of the project is the Netherlands Art Institute. The project is about gene therapy for the treatment of inherited arrhythmogenic cardiomyopathy. In this context, today we will have a chat with two different individuals that are involved in this project. We will have Ruth Biller from German Arrhythmogenic Cardiomyopathy Patient Association. And we will have as well Fidra Loque from Catholic University of Leuven, which has conducted this study, which gives the title to today's webinar. We move forward to the rules of the webinar. So all microphones will be in mute. The webinar is recorded. You can always use the Q&A box for your questions, because my colleagues from UPATI are monitoring these messages. Then I will also say that during the presentation you will have some sliders, because we want also to keep an interaction with attendants of the webinar. And I think from my side, it's more or less everything for now. I will now ask Ruth Biller to introduce. So as I said, Ruth Biller is coming from a German ACM patient association. I will ask her to introduce us this health condition, which is the focus of Jeremy project and as well of the study conducted by Fidra Loque. And Ruth will tell us more about the definition of the health condition, the diagnosis, but also the challenges and the therapies that exists in this moment. So I will give the floor to her. I will stop sharing my screen, and now technically Ruth will share her screen. So sorry for this moment, but I think in a couple of seconds her screen will come. Okay, it is perfectly visible. So Ruth, I give you the floor. Thank you.
Yes, thank you, Enrico. I'm Ruth Biller. I'm the chair of AFAT for Germany and co-founder of the organization. I'm also chair of the European Patient Advocacy Group in ERN Guard Heart, the European Reference Network for Rare Heart Diseases. So I will tell you something about arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy is we have the typical right dominant form, which was known as ARVC, arrhythmogenic right ventricular cardiomyopathy, affecting the right ventricle of the heart. But there are also left dominant forms called sometimes ALVC, or non-dilated left ventricular cardiomyopathy, sometimes overlapping with dilated cardiomyopathy, DCM. And we have also biventricular forms affecting both chambers of the heart. So what does ACM mean? The healthy heart muscle cells are destroyed and they are replaced by fibrotic tissue and scars and fat. And it's mostly genetic. So most of the time there are whole families affected. And the highest risk of disease onset is between 20 and 40, but there's also early disease onset known in childhood, and it can be at every age actually. So what are the risks? On short term, there are life-threatening arrhythmia with a risk of sudden cardiac death, also at young age. Sometimes, unfortunately, it's the first presentation of the disease. And long term, we see heart failure and in the end, cardiac arrest, so the heart just stops beating. The diagnosis of the disease is done by ECG with negative T wave and epsilon wave, frequent X-ray beats and Holter monitoring, and ventricular arrhythmia, for example, very fast heartbeat, known as tachycardia. The other important thing is echo and MRI, where you see the fibrotic tissue and the dilatation and the decrease of the pumping function of the heart. So the most important markers are the ejection fraction. In ARVC, it's the right ventricular ejection fraction, and in the other form, the left ventricular ejection fraction. And also important late gadolinium enhancement, which is a marker for fibrotic tissue and scars with a high risk for life-threatening arrhythmia. Also important, the family history and genetics. So sudden cardiac death in patients below 35, so that's from the task force criteria which make up the diagnosis. There is still the limit of 35 years. In these days, we would maybe say 50 years because below 50, the risk is high to have a sudden cardiac death. So it's a suspected or confirmed ACM in the family or a gene test with a disease-causing variant. So genetics are really important. Wait a moment. So there are many challenges. I'm not sure, I skipped one of my slides. Yeah, here, the genetics. The diagnosis of ACM is very important. The genetics, 50 to 60% of our patients carry a genetic variant. So the most common ones are PKP2 and DSP. The gene variants are part of the diagnostic criteria. They are called revised task force criteria from 2010. They are still very valid for ARVC. The Padua criteria introduced in 2021 are the attempt to also have task force criteria for the left dominant and biventricular forms. So carrying a disease-causing variant is a major criterion and makes up sort of half of the diagnosis, because two major criteria are already a definite diagnosis of ACM. So family screening is very important. That's why genetics are so important, because if you have identified a disease-causing variant, cascade screening in the family is offered, which means you're looking for the parents. Is it the mother's side or the father's side? You're looking for the children of the affected person and also for siblings. So then you can have one family. If the family is negative, then you can discharge them from follow-up. And gene-positive family members need to be evaluated carefully to detect early signs of the disease. So the advantage if you have a gene is that you can identify the persons at risk in your family. Genetics is also very important for prognosis and risk stratification, because different gene variants cause different disease courses. So some variants carry a very high risk for sudden cardiac death, like TMEM43, PLN, DSP, FLNC, and so on. And so then you can have decide for an ICD implantation to prevent sudden cardiac death, depending on the risk profile, and this depends often on genetics. So there are some challenges in the diagnosis of ACM. So the sudden cardiac death in the family is a very devastating event in a family. So from the 440 patients and family members on our mailing list, nearly every fifth has lost at least one family member to sudden cardiac death. And 11 families have lost even more, so 2 family members or more. And it's also, the disease has also a very heavy psychosocial impact. So we see many anxiety disorders, depression, post-traumatic stress disorder after sudden cardiac death or cardiac arrest or ICD shocks. Then the guilt of having passed on the disease to the children. And we have a high rate of frequent hospitalization, early retirement, and premature death. We will hear more about that from Phaedra later. And the biggest challenge in the diagnosis of ACM is the average time from the first symptom to diagnosis. In our community, it's at the average 8 years. So that's far, far too long. That's numbers from 124 index patients. So index patient is the first diagnosed patient in the family. And the good news is that more than a third are diagnosed within a year after the onset of the first symptoms, but nearly a third is diagnosed after more than 10 years, and this should definitely change. There are some red flags, so some sources of misdiagnosis. The most important one in ACM is myocarditis. So in our community, we have more than 59 cases. So that these are the only ones, only the ones I know about. So from some of our community, I don't have the disease courses, but 59 cases in more than 300 patients. That's quite a lot. So 16% of all our ACM patients and 21% of the index patients on our mailing list have had myocarditis. Most of the cases with PKP2 and DSP gene variant. And it's so important because after a normal myocarditis, people are allowed to return to sports after 3 or 6 months, and in ACM, return to sports may be fatal. The second red flag is a syncope. So we have more than 27 cases, so 10% of all our ACM patients and 11% of the index patients on our mailing list have had a syncope, and most of the cases with PKP2 gene variant. And the important thing to know is that there's often epilepsy suspected, but it's not an epilepsy, but it's caused by an arrhythmia. The third red flag is just unexplained arrhythmia, also atrial fibrillation. Also in the normal population, people would think this is a disease of old women and men, but atrial fibrillation in one person can be a cardiomyopathy, and also unexplained heart failure. So especially in cases where there's an unknown origin, and especially in young, apparently healthy women and also men, but in women it's more frequently. And in our community, there were many patients who were sent to a psychologist to treat their so-called psychosomatic symptoms, although they had a life-threatening disease, or they are even sent home and they are told to be young and healthy. So how can you treat arrhythmogenic cardiomyopathy? So we have drugs. Nearly all the patients take beta blockers or some antiarrhythmic drugs to treat the arrhythmia. We have heart failure drugs to support the pumping function of the heart. If the arrhythmia medication is not enough, we can do catheter ablation. So the fibrotic tissue can be ablated, and then the arrhythmia goes away. The problem is that there are new patches of the disease and then new arrhythmia. So this is only normally for a short time. In high-risk situation, we have the implantation of an ICD, an implantable cardioverter defibrillator, which is sort of an emergency doctor which is implanted into your body. It delivers a shock in case of life-threatening arrhythmia, so it's really life-saving, but it's also, of course, a source of side effects like lead fracture and inadequate shocks and everything. But of course, many, more than 50% in our community have an ICD, and it's has often been life-saving for them. And the last option is a heart transplantation in case of untreatable arrhythmia and end-stage heart failure. So if everything else fails, it's only heart transplant which can save the patient's life. But all these therapies only treat symptoms. There's no causative therapy available. That means there is no cure for the disease. So that's why there is a desperate need for new therapies that reduce recurrent arrhythmia more effectively, that have fewer side effects, that stop disease progression, and that, of course, ideally cure the disease. So just some facts and figures of my patient organization. The patient organization was founded in 2013 and is a non-profit organization since 2018. Our reach is more than 450 persons on our mailing list and more than 300 patients and gene carriers. So nearly 70% of our index patients are carriers of a likely pathogenic or pathogenic gene variant, which means disease-causing gene variant. So that's a bit more than in the literature. And the treatments in our community are the medication, which I told you before. 68% have an ICD, 25% had a catheter ablation, and 2.5% had a heart transplant. And actually, there are 4 more in the process of being listed. So what do we provide for patients? We provide information and education, so comprehensive information in lay language on our website. We have a yearly program with 2 expert presentations on different topics twice a year with slides and or the recordings of our website. We have an own YouTube channel for that. We even have a YouTube channel for doctors. And we have also Q&A sessions by experts for patients where patients can just ask questions about their personal disease cause. Then we have peer-to-peer support and counseling, online group meetings for patients and family members 3 times a year with breakout rooms to different topics. We have online group for young patients under 40 years, which is monthly. We have a moderated patient forum. It's integrated in our website, and we have trained local contact persons, and we do counseling via email, phone, or Zoom for the patients, also to connect them to the next expert center, for example. We have also networking events. So we have an ARVC day every 2 to 3 years with 100 to 150 participants with experts from our scientific advisory board. So on the photo on the right, you can see some of our scientific advisory board. They are, of course, all from Germany or Austria or Switzerland. And for example, you can see Brenda Gerol. She has found the PKP2 gene nearly 20 years ago. We have also a patient weekend every year with 25 to 30 participants. Actually, for this year in November, we will have 40 participants, which is the highest number we ever had. And we also recruit for surveys and studies via our website, newsletter, or email. And this is why I'm doing all this. This is my daughter Judith. She died of sudden cardiac death at the age of 14 in 2011. And I want to spare other families this fate because losing a child is, it's hell. And I can only tell you that every single life our community can save is worth it. And I thank you for your attention, and now we have some questions for you, for the audience, to make it a bit more lively. Thank you.
Yes, thank you very much, Ruth, and thank you for your work and commitment for the patient community. Thank you very much. So now we have this slide. I think you want to continue, Ruth, presenting the question, and then I will come back just after the slide. But just wanted to say thank you again.
Yes, so I wanted to ask you, what are your biggest challenges in living with ARVC? So just type something into the Slido board, and then We will see afterwards what your challenges are.
Sorry, I don't see any replies. I don't know if someone has, like, if you can access the Slido correctly. Could someone let me know?
Oops.
Yes, this is the code, I think.
Ah.
I see. Perfect. Thank you. If someone faces any problem, please text on the chat and we will try to help you.
I see that still one participant is typing.
Okay, interesting. Children, yeah. That's also what we see in our community, that people are more afraid about their children than of themselves. Interesting. Yeah, there was also, I saw a question in the Q&A box about sports. That's true. I omitted it, this part. It will be in the in Phaedra's presentation, I think. It's of course one of the big challenges is sports restrictions. Yeah.
Okay, I think we have a certain number of questions. So this biggest one is children. So I think it is related to next generation and how it is transmitted as well to the coming generation. At least that's my interpretation of children. What do you think, Ruth?
Yeah. Should we do the next slide? The next question? So how long did it take from your first symptom to the final diagnosis, or the first symptom of your family member, if you're a family member who has joined? So less than 1 year, 1 to 2 years, 3 to 5, 5 to 10, or more than 10 years. everything in it. Yeah, in our community, we see most of the people who are diagnosed quickly are the ones with a heavy presentation, like who have survived a cardiac arrest. These are most of the times the ones who are diagnosed within the first year. Okay, it seems that no one types anything. So maybe we go to the, that's very interesting. So it's very, the results are very diverse. So that's what we also see in our community. So everything is possible between 1 and I think 43 years was a one with the longest. She had experienced symptoms from teenager, and now she's 60, and now she's got the diagnosis. Wow. Okay, shall we go to the next? Yeah, so what was the initial diagnosis? So if you were diagnosed right away, then just type ARVC or ACM. And if you had another diagnosis like myocarditis or something else, psychosomatic symptoms, please type your first diagnosis. Yeah, as I said, myocarditis is a top diagnosis before ACM. Yeah. And also this overlap with DCM. Can see this. Okay, so thank you very much.
Thank you, Ruth. Thank you again for your contribution. And then we will move forward to Fidra Luque from Catholic University of Leuven. She's PhD candidate, and she will tell us more about her study, her investigation about unmet needs of patients. I want to underline that in the context of this project, Jeremy, led by the Netherlands Art Institute, where UPAD is a partner as well of the Catholic University of Leuven, and contributing together in the same work package with the PLN Foundation from the Netherlands. We are working very closely with patient experts. Also, this work from FIDRA is coming from collaboration with patients. Patients replied to her survey, but she worked with patients for the co-creation, let's say, of the survey. So listening to their needs and to their feedback. So there was an interaction with patients even before submitting the survey to the survey population. Now I will leave the floor to her, and yes, we will be very curious to listen to her study and the methodology, the results, and as well the conclusion.
Okay, thank you, Enrico, for introducing me. Can you see my slides? Okay. Let me just. Okay, so indeed, in the past year, I have been working on my first study of my PhD, and I'm very happy to present to you today the results. So as already mentioned by Ruth earlier, we see that several elements are of importance throughout the journey of a person living with a certain condition, and the literature shows us that patients can experience a range of needs that are related to their health, to their healthcare experience, but also their participation in social activities. So as you can see here, these needs can encompass an impaired health-related quality of life, but also physical, psychological, and reproductive challenges. Furthermore, we also see that patients can experience challenges related to the effectiveness and burden of their treatment, but also related to the quality and accessibility of their care. As well, we see an impact, and also already introduced by Ruth, an impact on the condition on their social life, but also potentially on the education, work, and financial situation. All elements that significantly contribute to the overall quality of life of patients and patients' satisfaction. So in recent years, there is an increasing number of stakeholders that have emphasized the importance of identifying patients' unmet needs, because doing so can improve patient care and guide the development of strategies and therapies to effectively address the needs, which ultimately helps us to move more toward a needs-driven healthcare ecosystem. And to date, there is in the literature little to no patient experience data available for this particular population. Luckily, there are still patient organizations such as the one led by Ruth, but also other European organizations such as the PLN organization that is part of the Jeremy project, help to represent the voice of patients. However, systematically identified evidence is still lacking to this date. And for this population, it's particularly relevant to understand the needs of this population, as today there is a lot of new developments and investments made to develop new therapies, in particularly gene therapies, and therefore it's we need to identify the challenges that these patients face today and how we could address them. Are these new therapies something that could help address the needs that they are experiencing, and how can we integrate these needs for successful adaptation and implementation of future therapies in the future. Therefore, we disseminated an online survey or a survey to carriers living with the genetic form of arrhythmogenic cardiomyopathy in Belgium. They were personally invited by a cardiologist at University Hospital in Leuven, and they could self-complete the survey either online or in paper in their native language. So as Enrico already mentioned, the questionnaire was based on multi-stakeholder developments, but originally based on the generic patient survey developed within the needs examination, evaluation, and dissemination framework, which is a framework that is developed to identify unmet needs across conditions in a generic and systematic way. And we tailored the survey for this patient population, and we did that by collaborating with several stakeholders, including healthcare professionals, cardiologists, geneticists, but also patient organization, Myopathy fellows, to enhance both the clinical relevance and the patient relevance of the study. We also conducted a pilot with several patients to ensure that the questions were understandable and requested their input to be able to develop a survey that was understandable and relevant to this patient community. We were able to collect 112 responses, which correlates with a response rate of 62% of the diagnosed patients in the University Hospital at Leuven. We saw an almost equal distribution of men and women, and most participants were between 40 and 50 years old. Most of them had a higher level of education, but there was still also a notable number of people with a lower level of education that completed the survey. Most participants were working at the time of completing the survey and were already experiencing symptoms. So going further with the results, on the first level of the health needs, we assessed patients' quality of life across different dimensions. So for symptomatic patients, this was done at 2 time points, so retrospectively before the onset of their symptoms and at present. And then for asymptomatic carriers, assessments were made at present only. And so the results highlight here the domains with the greatest impact. So what we can see is that symptomatic carriers report significant problems, and in some cases even extreme problems with their daily activities, as well as they experience lots of pain and discomfort. Moreover, we also see that half of the symptomatic carriers experience issues with anxiety and depression, which we can also see among the asymptomatic carriers, highlighting that, as already mentioned by Ruth in the introduction, that there is already a psychological burden of living with just a hereditary condition, even in the absence of symptoms. We also found that there was a significant decline in the quality of life following the diagnosis of arrhythmogenic cardiomyopathy. Then going further on the impact on patients' reproductive health, we saw, so more particularly in relation to their desire to have children, and we see that for 52% of participants, their desire to have children had already been fulfilled before receiving a diagnosis. This means that these patients did not have the opportunity to make an informed choice regarding alternative reproductive options. As we see that there's still a small number of people who did report an impact because they were diagnosed already and had the option to consider other reproductive options. And there we see that most patients considered IVF or decided not to pursue any further pregnancies because they were not willing to anymore, or they were advised not to get pregnant because of their condition to protect their health. And what we also see is that at the same time, we observed that a considerable number of carriers did choose not to let the condition influence their reproductive decisions as well. So again, we see a variability here, but as already shown as well by the question of Ruth, the impact on reproductive decisions and children plays a big role within this population. Then going further to the healthcare needs, we assessed the satisfaction and the burden of the treatments that patients are currently receiving. And we see that overall, carriers are rather positive about the treatments that they received or have received. But if we look a bit closer, we saw it in the beginning a bit as well, is it shows that strategies that affect carriers' daily life, such as lifestyle adjustments, stopping playing in competitive sports, or undergoing surgical interventions, which often involve hospital admission, are perceived as the least satisfying. Furthermore, half of the respondents perceived the treatment as slightly too extremely burdensome, and this was mostly because of the experience of side effects, but also because it forces them to constantly manage their illness and treatments and requires a stricter lifestyle discipline. And then I also have a Slido question, so let me see if I can stop sharing my screen. So as mentioned, we okay, yeah, there are gene therapies currently being developed for people with this condition, and with these gene therapies, they aim to correct the genetic mutation and stop the progression of the condition. So my question to you is, how do you think that these new gene therapies could meet the needs of people that are currently living with cardiomyopathy or not, and how would that be the case? I see that there's still 2 participants typing, so I'll wait for their responses. So indeed, it suggests to stop the disease progression, and that could allow patients that are in the early stage of the condition, that are not severely affected yet, to allow for better participation in their daily activities, and potentially delay further surgical interventions, and as mentioned here, improve the living with the condition, as it could delay severe interventions. So far, there is support from the community. I'm also conducting interviews right now with patients, and we see that patients are rather positive about it, but there is indeed a hesitancy towards the side effects of the therapy. And also there is the question, okay, gene therapy appears to have the biggest clinical benefit as in the earliest stages of the condition, but it's debatable whether patients would be at that stage would be willing to receive gene therapies or not. Okay, thank you for your answers. Can I go back to my presentation? Let me see. Okay, yeah. Okay. Then we also assessed the patient's pathway to diagnosis and treatment. So as shown by Ruth there in Germany, or in her community, they saw that the average was around 8 years. Here, this graph shows us that for some patients, it can take more than 4 years as well to receive a diagnosis of arrhythmogenic cardiomyopathy. here it's important to note that these were not only index patients, meaning that there are potentially also family members on the same family that were answering these questions, which could have reduced the timing. But here this graph shows us as well that there is still a diagnostic delay, leaving patients without close monitoring of their arrhythmias at risk for life-threatening cardiac events. And furthermore, we also assessed how carriers discovered that they were carrying a genetic condition. And as we see, the majority were identified through genetic screening after a family member was diagnosed. Only 26% followed a traditional diagnostic pathway where they had their first symptoms and decided to consult a doctor, but there was still nearly 30% that had to first experience a life-threatening event themselves or within their family before undergoing further clinical testing. So they had to be admitted to the ER after a cardiac event before further clinical testing was performed, or a sudden passing of a relative led to further additional tests as well. So for arrhythmogenic cardiomyopathy carriers, this highlights that many carriers remain unaware of their condition until an acute event occurs, and this underscores the importance of genetics and the early diagnosis to prevent severe outcomes such as sudden cardiac death. Then in relation to access to information, we assess the extent to which patients receive timely and useful information from their healthcare professionals to help manage their health and well-being. And what we see is that more than half of participants reported that they do not always receive such information. But at the same time, when we asked them which sources they find most useful, patients still indicated their doctor and specialist, suggesting that there's still a certain level of satisfaction with the information they do receive. However, in comparison to Germany, there is no patient organization in Belgium for this condition, which could explain an important gap in terms of patient education and accessible information, as these are often the objectives of such organizations, which is still lacking in Belgium. So the establishment of such organization could already partly bridge this gap. And then finally, going on to social needs, we assessed whether patients experience difficulties in different areas of their social life. And we observed a notable number of carriers that reported an impact, and most prominently in relation to hobbies and interests, holidays, and householding tasks. We also see that even asymptomatic carriers already reported a considerable impact on their holiday experiences. These findings highlight how personal experiences that are central to many individuals' sense of fulfillment in life can be significantly impaired by living with a certain condition. And I wanted to add here as well a quote from one of the participants stating that I love team sports, but I can't keep up anymore, and I'm the weakest on the team. After 20 years, this season will be my last. It's so hard to move on, as sports were my main social outlet. Friends are drifting away, and I can't join them for concerts or outings. They're too exhausting. I feel lost and increasingly isolated. So here you see, and it was also mentioned by Ruth, that there's definitely an impact on patients' social life and social participation. And then I have again a Slido question. What do you think that could be the reasons why asymptomatic individuals are already experiencing unmet needs? Sorry. Stop sharing. Yeah. Okay. So we see psychological burden, and indeed, I think Ruth maybe can confirm this, but we see that living with only already a risk on having sudden cardiac events, but also at an individual level, but also within their family, brings psychological distress. If some even experience guilt of giving the condition to their relatives as well. Furthermore, the condition is also has a variable expression, meaning that it's difficult to give a good prognosis to patients, which leads to a big unpredictability of when their symptoms could occur, of when their disease could become worser. Indeed, this is mentioned here as well, the fear of developing the disease. So not everyone will develop symptoms. And I see as well here not taken serious. I think this also relates to the challenges with diagnosis as well. Okay, thank you so much for participating. Oh, I see it's still one person is typing. I'm not sure what was added, but okay, thank you. I will start sharing my screen again. Can you see it? Okay. Then further, this is my last slide with my results, I think. We also assessed the impact on their work life and financial situation. And basically what we see is that almost half of the participants of the symptomatic carriers experienced an impact on their work intensivity, meaning that it was a reduced work intensivity, which was often caused by reduction in working hours, the inability to continue shift work, taking on fewer responsibility, or even opting for early retirement. Also, among asymptomatic carriers, we have already observed these patterns. And then at the level of financial impact, we see that half of the symptomatic carriers reported experiencing financial difficulties because of living with this condition. And these difficulties most often stem from a loss or lack of employment, a reduced income, and increased medical expenses. And I have another Slido. So how could these results shape the way, so how could the results that I presented today shape the way people with arrhythmogenic cardiomyopathy are cared for in the future, and how should we apply these? Okay, thank you for commenting. I think we all agree with what has been written here. And I think that was also the objective of the study, to make awareness about this rare disease, community in the literature, to make systematically identified data, quantitative data on the needs of these populations to inform indeed health policy, but also priorities in research settings, priorities in healthcare settings. For example, during the interviews I'm conducting with the patients, lots of them mentioned to me saying that, okay, they care for my heart, which is very good, but they only look at my heart and they forget my psychological or mental health. So, which I hope to highlight as well with the results of this study, that there is a significant psychological impact among these patients, and hope to bring more awareness about that as well. Okay, and I have then to finalize my presentation, my conclusions. So based on the results, we see that in relation to their health, that we see that there's a need for targeted psychological support for symptomatic, but also asymptomatic carriers. Patients have a need to get more control over the symptoms. It was not presented here, but there was also a burden reported related to the unpredictability of their condition, as well as the need to maintain their daily activities. Furthermore, we saw a need for improved diagnosis to give patients or carriers the opportunity to explore alternative reproductive options. And then at the level of patients and the healthcare system, we see that there is a need to develop treatment options that require minimal lifestyle adaptations. I haven't shown it in the presentation, but it was already mentioned by Ruth. The unexpected defibrillator shocks were also perceived to be burdensome to patients. So the minimization of unexpected ICD shocks would be a great achievement, as well as access to timely and useful information, potentially by patient organizations in Belgium, and the need for timely diagnosis. And then at the level of social needs, we see that there is a need for treatment strategies that support social and professional participation, and eventually financial assistance to alleviate economic burden. And by identifying these needs, we hope to tailor gene therapy, but also other drug developments, healthcare settings, and treatment decision-making to the needs of patients. Then I want to thank the whole team involved, so my colleagues and my supervisors at KULeuven, but as well as the clinician at the University Hospital in Leuven, the different patient organization, as well as UPATI for the UPATI fellows for giving their input on the survey, and as well Jeremy for the funding. Thank you very much. I can also already say that there is a pre-proof version available of the article right now if you want to learn more about it. Thank you.
Thank you very much, Phaedra. It was incredibly interesting. I want, just before opening the Q&A session, I just want to say again a few words about the Journey project, which is a project trying to answer to patient needs, at least at therapy level. I just want to refresh that the Journey project, it's a collaborative project involving different partners from different countries, led by the Netherlands Art Institute, and very multidisciplinary approach. Here, researchers are working and trying to achieve an ambitious aim, which is developing the first cardiac gene therapy for the treatment of arrhythmogenic cardiomyopathy. So this webinar and also Phaedra's study was in the context of this collaborative project that started the 1st of May 2023, and it's still running. Now, I will just check with my colleagues if we have questions in the Q&A. I already see one of them. Okay.
I already answered one. So there
Do you
was a
foresee-
question about skipping generations. So normally arrhythmogenic cardiomyopathy is
Yes.
autosomal dominant inherited, so it doesn't skip generations. So you have the chance of 50% to pass on the disease to your children. But there are also some rare autosomal recessive syndromes. In these cases, in these very rare cases, generations can be skipped.
Thank you. Yes, actually, this question is coming from the chat box. You're right. In the Q&A, it's a different box, and we have some other question there. I'm just checking also the chat if something else is there. Apparently not, but please tell me if you find something more here. I see in the Q&A, I was saying another question. If you foresee to extend, I think it's addressed to you, Fidra, if you foresee to extend the study also to other countries.
Yes, and we did actually. I also worked together with Ruth and the PLN organization and several other patient organizations across Europe, and we disseminated the survey in different countries. We were able to collect more than 200 responses by now, but I need to start the analysis. And we also included some questions about the need for genetic interventions and therapies. I cannot answer the question right now, but it's still coming. So I did that for the study, and there's also a qualitative study coming up, which I'm working on right now, in which I do interviews with carriers to see to what extent that they are willing to receive gene therapy at the different stages of their condition, and what elements treatment related but also disease related are of importance to them when making a decision between their current therapies and a gene therapy in the future.
Okay, and then I see another question. According to you, what are the most important steps to disseminate information about the condition? And I think here it is referring more to countries where, like in Belgium, you don't have patient association that are making dissemination. So the question again is to what are the most important steps to disseminate information about this health condition?
Yeah, I think what we see here is, and what we saw in the study is that doctors are still the most reliable source or indicated. And since there's no patient organization yet in Belgium, I think there's of importance of clinicians to guide patients to the right sources and guide them to, other patient organizations. For example, in neighboring countries, we have the PLN organizations. In the Netherlands, of course, it's a organization mutation specific, but it can already help people that are living with another genetic variant as well. It's a rare condition, so potentially there is not enough to find on the internet in their native language, and I think that could also already help by developing educational material for patients that are living with a condition like this one.
Maybe I can also comment. First of all, there is the ERN-Guard Heart website where you can also, there are disease-specific brochures in many different languages in there. I mean, it's very short and but basic information on the diseases. So you can have a look at that. And I thought it was very interesting when I read Fidra's study that there's in Belgium, there's nobody is relying on a patient organization because there's no one existing. And I think I'm very curious about your findings in the broader survey, because I think in Germany many people rely on our information. We have a website with really a lot of information on it, all in German, of course. But we know that even doctors who are not experts go onto our website to get informed if they have ACM or ARVC patients. So it depends on if you have an active patient organization or not.
Okay, thank you very much. There is another question from a patient advocacy standpoint. What role can patient organization play in influencing early access to innovative therapies or registries for this rare condition in Asia Pacific region and beyond? I don't know if we can answer to that. Actually, it's a bit very complicated and local, let's say, question. So do you have any of you has any knowledge about how to promote early access to innovative therapies in Asia Pacific and this region? Or do you know any patient organization?
I'm not sure if we can provide this. What I'm doing is I'm also part of the Cardiomyopathy Council of the Global Heart Hub. The Global Heart Hub is an international heart patient organization, and there is a possibility to join if you have a cardiomyopathy patient organization in the Asiatic in Asian country, you can also join the Global Heart Hub Cardiomyopathy Council, and we are driving awareness campaigns every year to raise awareness about cardiomyopathy. So all cardiomyopathies, not only ARVC or ACM, but this could be a possibility to have more impact also. So we have now an organization from India and from Brazil, so why not from Asia? Yeah.
Okay, thank you very much. Yes, I don't see any further question. I'm just looking at the chat because if everyone has okay, here someone was saying that we have no tradition of heart patient organization in Belgium. So this might be one of the reason why in Belgium this any patient organization or association exists for the moment on this health condition. Apart of that, I don't see any other question. I don't know if you want to add something, both of you.
I may just add that being the chair of the European Patient Advocacy Group of ER and Guard Heart, we are for 7 years, I'm looking for a Belgian cardiomyopathy or rare heart disease organization to join and to have a Belgian voice represented in our group. So I know about this, but maybe one of the participants today wants to I mean, you know, when we got the diagnosis in our family, so it's not only that my daughter died of ACM, but my husband and my son are affected, as well as many other family members of the wider family. We asked about a patient support group, and the doctor said, well, nearly everybody asks about it, but nobody has ever founded one. So why, you are a big family, why don't you do it? And then we just did it. So, and I mean, if you had told me that I would give presentations 10 years later, I would have maybe told you are crazy. So things are evolving. JART starts small and things can evolve, and now we are really big patient advocacy working in Germany, in Europe, and internationally. So just do it. You have just to start.
Thank you, Ruth, because that's a wonderful example that you are giving to all of us. And thank you very much for your energy and your commitment. That's really wonderful what you say. maybe someone can just wake up and say, okay, let's make it. Doesn't exist, let's make it as you did it, and that's wonderful. Fida, do you want to add something?
No, not particularly. I think I'm happy to present my results, and maybe we can organize another webinar in the next year if I have finalized my next study. And I want to thank everyone for attending the webinar, and Upati as well for organizing. I was very happy to present today.
So again, it's a moment of thanking everyone. So thank you very much for attending, to all the participants to this webinar. Thank you very much to the panelists, thank you to your patients and your collaboration. And see you next time. So Fida already said that we might have another webinar next year. So thank you again. Have a nice afternoon. Bye.
Thank you. Bye-bye.
Good afternoon. Bye-bye.
Bye.